Hello and welcome to this video. Today this is going to be an interesting case, and this is a case of a child with vomiting. So without further ado, let's start with this case. This is a 2-year-old boy who has got a past medical history of Hirschsprung disease, and he presents to the emergency department with a history of vomiting for the last 2-3 days. Apart from vomiting, he has also developed swelling of his abdomen, and he is unable to tolerate oral feeds, oral fluids for the last 1 day. Now, his parents have been instructed by his pediatric surgeons to perform rectal irrigations 2 to 3 times daily for the first few days prior to this presentation. So, to sum up this case, a 2-year-old has got a past history of known Hirschsprung disease. He is under a pediatric surgeon, and for the last 2 days, he has developed vomiting, he has developed abdominal distension, and he cannot tolerate oral fluid. So he has failed oral fluid challenge. And for the last few days, his parents have been doing rectal irrigations because they have been advised by the pediatric surgeons. So in other words, he hasn't had any proper surgical operation so far for his condition. He's on conservative management. Now, on examination, his vital signs are within normal limits. So his heart rate, blood pressure, everything is fine. Though on a general outlook, he appears to be a bit lethargic and slightly pale. On examination of his head, ear, and nose and throat, his oral mucosa appears to be a bit dry. So there might be an element of mild dehydration. On his abdominal examination, the abdomen is moderately distended, and when you auscultate for the bowel sounds, they are slightly sluggish or decreased. The skin turgor itself remains normal, so the skin pinch goes back immediately. So, because of his history and because of his presentation, you decide to go with abdominal X-rays. Remember, in this type of presentation where a child has got a pediatric surgical condition already known, and he presents with acute abdominal pain, acute vomiting, though in this particular condition it's non-bilious, but irrespective whether it's bilious or non-bilious, and he appears unwell, in that case the first investigation or the best next step would be to do an abdominal X-ray. And you have to do an abdominal X-ray because you have to rule out bowel obstruction, you have to rule out toxic megacolon, which are usually complications in these types of conditions. So moving on, let me show you the abdominal X-rays. Here you can see the abdominal X-rays. There are two X-rays. One is the supine view, the other is the left lateral decubitus view. So if you focus on this supine view, obviously this is not the erect one. This is because obviously child is unwell, they are not able to stand. He's 2 years old, so supine X-ray has been done. So if you see, you can see a very large gaseous shadow below the liver, quite a big one. And then you can see here, if you focus on the descending colon, you can see that there is absence of gas shadow in the lower part of the descending colon, even in the sigmoid colon, and you can't find any gases in the rectosigmoid area. So if you zoom on to this area, you probably would see that there is a lot of fecal material in this particular area. So obviously the first impression is that probably, and again because of the underlying condition is Hirschsprung disease, you think that he's probably bunged up, he's got a lot of constipation. But remember, the constipation should not account for relentless vomiting. It should not make him unwell. It should not cause like severe abdominal distension and inability to tolerate oral fluid. So something more is going on apart from constipation. Here you can see a little bit of more like probably fecal material or an homogeneous dense material in the upper part of the what we call as the splenic flexure. And with that, you can also see that there are a few gases over here. So you can see there is a lot of gases in the transverse colon. So this transverse colon going up to the hepatic flexure is full of gases, and then you can see a lot of like inspissated stool, or fecal loading of the descending colon and the rectosigmoid area. So apparently looks like constipation, but this is something more than the constipation. And then if you look at the lateral decubitus view, you can see here that he has got the air fluid levels. There are many air fluid levels in different parts of his abdomen, and this simply means that there is some element of intestinal obstruction as well. So obviously, when a child has got Hirschsprung disease and he has got air fluid level, he means that he has developed bowel obstruction. But why he developed bowel obstruction? I mean, obviously he's got Hirschsprung disease and he's having rectal irrigations, every day. So remember, some of the common complications which are associated with Hirschsprung disease is number one, intestinal obstruction. Number two, it can lead to toxic megacolon, where there will be a dilatation of the descending or any part of the colon. And then the most important diagnosis which you should not miss is what we call as Hirschsprung associated enterocolitis. So in a child who has got Hirschsprung disease and he presents with an acute presentation which is related to his tummy, like abdominal distension and vomiting, so there are a few complications that you should be thinking about. The most important is intestinal obstruction. Remember, because of the absence of myenteric plexus and because of the constriction in the lower part of the rectosigmoid area, they can develop acute intestinal obstruction, obviously because they haven't pooed, and constipation can lead to that. Number two is toxic megacolon. So toxic megacolon is actually dilatation of the descending colon or the rectosigmoid colon caused by infection. And the third important thing which you should not be missing is the Hirschsprung disease associated enterocolitis. Now that is a fatal condition and it can present with very non-specific signs, as in this particular case. So this was a case of Hirschsprung disease associated enterocolitis. So it can present with non-specific signs and symptoms like fever, irritability, abdominal distension, could be diarrhea, could be vomiting, inability to tolerate oral fluids, and they can have a mild fever as well. So remember that some of the other differential diagnoses which you have to keep in this mind, I mean, which are usually the differential diagnosis of any child who's got like vomiting is could be viral gastritis, first presentation of diabetic ketoacidosis, pyloric stenosis is a very small one, the acute appendicitis if it is right-sided abdominal pain, intussusception in the young one, again, which has got very non-specific symptoms, urinary tract infection, intestinal colic, toxic ingestions with certain types of drugs or recreational drugs, incarcerated hernia if they've got a history of hernia, and sometimes bowel obstruction secondary to malrotation. I think so. There is a very big differential. But remember, in this particular case, and if the child is known to have a history of Hirschsprung disease, which has not been operated, even with operated, sometimes they can develop like intestinal obstruction because of the fibrosis or like fibrous bands which can compress on the bowel loops. But anyhow, in a child who has got Hirschsprung disease and presents with vomiting and no specific symptoms, emergency medicine doctor or an ED doctor should maintain a very high suspicion of Hirschsprung disease associated enterocolitis, because if it is not detected well in time, it carries a very high mortality. So the immediate management of this condition is that you have to place a rectal tube. So you have to put a rectal tube, so at least the child, if there are any gases or something, they can pass out and they do not cause distension, which can sometimes lead to intestinal perforation as well. You have to immediately start them on broad spectrum antibiotics, which should be covering your gram-negative organisms as well as anaerobic organisms. So probably cefotaxime or ceftriaxone along with metronidazole is a very good combination to begin with. They should also be given IV fluid. Obviously, they are vomiting, so you have to replenish the lost fluid. So the deficits have to be made up for. Similarly, because the child is not tolerating oral fluids, so they have to be given maintenance fluid as well. So maintenance plus deficit, plus if there are any ongoing losses, you have to combine that and give them as IV fluids. And it's very important to immediately contact your pediatric surgical colleagues, because if something untoward happens, they might have to do an immediate laparotomy or might have to do an immediate surgery. So remember, Hirschsprung disease can present with complications, and those complications are intestinal obstruction, that is toxic megacolon, and Hirschsprung disease associated enterocolitis, which should be detected by the emergency physician, because I told you the signs and symptoms are non-specific, and if undetected, it can have fatal consequences. So this was all about Hirschsprung disease associated complication in a form of interesting case. Hope you have enjoyed it. And before I end this lecture, if you are new on my channel and if you don't know me, my name is Dr. Sayed Kazmi. I make videos on topics of pediatric interest. And if you like my videos, please give me a thumbs up. And so far, if you haven't subscribed to my channel, please do subscribe and press the bell notification icon. So whenever I upload a new videos, you're always on board with me. So have a very good day and Merry Christmas. Bye-bye.